también en nombre de la doctora Nadina Rubio, coordinadora del grupo de reumatología pediátrica, les doy la bienvenida a la sesión académica de pediatría del día de hoy, 30 de agosto, donde estaremos hablando de lupus pediátrico por la doctora Ekemini Ogbu. Les recuerdo que recibiremos preguntas a través del chat para que puedan utilizarlo y hacer sus comentarios durante toda la presentación, y al final tendremos un espacio para comentarlas a la ponente. También les pido por favor que modifiquen el nombre con el que aparecen en esta sesión. Esto es a través de la sección de participantes. Buscan el nombre con el que están actualmente, dan clic en más y después en renombrar para que puedan modificar el nombre y aparezca su nombre completo. Esto es importante para realizar sus constancias, al igual que el llenar la encuesta de satisfacción que aparecerá al final de la sesión. Ustedes la pueden localizar a través del chat o haciendo clic en el código QR que se presentará también al final. En nombre de la Escuela de Medicina y Ciencias de la Salud del Tecnológico de Monterrey, les doy la bienvenida a la sesión académica de pediatría. El día de hoy presentaremos el tema de manifestaciones clínicas y abordaje inicial de lupus pediátrico, que estará a cargo de la doctora Ekemini Ogbu, quien es reumatóloga pediatra en la Universidad de Cincinnati, en Estados Unidos. La doctora Ogbu realizó sus estudios en medicina y cirugía en la Universidad de Ibadan, en Nigeria, y después se trasladó a Atlanta, Georgia, para realizar un máster en ciencias e investigación clínica en la Universidad Emory, y después realizó su residencia en pediatría también en Atlanta y su especialidad en reumatología pediátrica en la Universidad de Emory y el Centro de Salud de Niños de Atlanta, Georgia. Actualmente, la doctora Ogbu es profesor asistente del Hospital de Niños, del Hospital Infantil de Cincinnati, y también es director de los servicios de enfermedades neuroinflamatorias y reumatología, y además es líder del Centro de Neuroinmunología y Esclerosis Múltiple del Hospital Infantil de Cincinnati. Es también profesor asistente adjunto de pediatría en la Universidad Johns Hopkins. Es colíder del grupo de trabajo en lupus neuropsiquiátrico de la Alianza de Investigación en Artritis y Reumatología en la Infancia, y es el líder también del programa de residentes del Colegio Americano de Pediatría, y también participa como miembro del Consejo de Reumatología Pediátrica en el grupo colaborativo del mismo Colegio Americano de Reumatología. Entonces, sin más preámbulo, thank you, Dr. Ekemini, for being here with us. We really appreciate your time and take a few moments to speak with our audience about this really important topic that it's usually difficult for, it's difficult for us as pediatric rheumatologists, but it's more difficult, I think, for pediatrics in general. So I give you the floor to start with your lecture. Thank you very much.
Thank you. Thank you for the kind introduction. I'm going to try and share my screen and hope this works again. All right. Can you see my screen?
Yes.
Okay, perfect. So first of all, I'd like to thank you all and the organizers for the invitation to speak today. I'm excited to be here and hope to get lots of questions at the end of this session. I'll be talking about clinical manifestations and initial approach to juvenile lupus. I have no relevant disclosures for this talk. In terms of the objectives for my talk, I'll give an overview of what juvenile systemic lupus is, and then review nuances of diagnosis in general of systemic lupus with emphasis on neuropsychiatric disease and lupus nephritis, and that's when lupus affects the kidneys. And then discuss the role of the general pediatrician in caring for a child with juvenile onset lupus. But first of all, just by way of history, because I do like history, pediatric rheumatology as a field hasn't existed for too long relative to other subspecialties. But we do know that as far back as in 1900 AD, we had children that were found to have arthritis. It wasn't until about 1904 when systemic lupus was actually first recognized in children. And even after that, long after that was when we had our first generation of pediatric rheumatologists. And so this talk is particularly important because it deals with a disease that is the second most common chronic rheumatic disease in children. So basically, as a general pediatrician, you are more likely to see a child with lupus and juvenile idiopathic arthritis than any of the other rheumatic diseases. So this is very important. Again, juvenile lupus is the prototypic systemic autoimmune disease in that if you talk about a disease where there is so much immunological dysregulation, then this is the disease. Despite advances in care and therapeutics and expertise in management of lupus, it is still associated with significant morbidity and mortality. In terms of epidemiology, it is a female preponderant disease. In essence, females are more highly affected than males. The male-female ratio in the pediatric population is about 5:1. And this compared to the adult onset disease, where it's about 9:10:1. So while in children, it's still female heavy, in adults, it's even more. When we talk about ethnic and racial differences, there is a higher incidence and prevalence in non-Caucasian populations. In the US in particular, it's higher in African American and Black populations, but also high in Hispanic, Native American, Pacific Islander, and Asian, very much so in comparison to Caucasians. Having said that, we do not have a lot of large epidemiologic studies in lupus, in pediatric lupus, compared to adult onset disease, but there is a study I like to often refer to that was published in 2011. They did a systematic review of epidemiologic studies that were in the literature from 1950 to 2010. They pulled out about 12 articles and one abstract. This was predominantly from North America, Europe, and Asia. Here they found the incidence of juvenile lupus to be 0.3 to 2.5 per 100,000 per year. And if you look in the table in front of you, you'd see that the number from Georgia, USA was particularly high in the Black population, where you had about 3.6 per 100,000 per year relative to the other populations. Of course, the reasons for those are multifactorial and we're not fully understood. Similarly, with prevalence, there is a wide range, as you could see there. This ranging from basically estimates from all over the world, and it showed that the prevalence was a range of 1.9 to 25.7 per 100,000. And it's a very wide range in frequency, and it's thought to be based on factors such as access to care, referral patterns, and of course, the ethnic and racial diversity of the study populations. And so we switch gears a little bit and talk about what is juvenile lupus and what drives the disease. Like I said, it is a prototypic autoimmune disease. In essence, it's not just a single pathway that is affected in lupus, but it's pretty much widespread. So you have total immune dysregulation and systemic inflammation in multiple pathways. Like I do like this cartoon because it really shows the different areas that are affected with lupus. The inefficient clearance up there. Sorry, I move my cursor a little bit. And then increased netosis from the breakdown of this cellular product and the altered immune clearance that's inefficient. And then you have deposition of immune complexes and complement activation at tissue level. Cardinal to this are the activation of the B cells and also the influence of T cells here. This, of course, is not the entire picture. The B cells in particular are predominant in the pathoetiology of lupus. This is because there is a lot of B cell hyperactivity with polyclonal B cell proliferation. And because there is a loss of normal B cell tolerance that should really happen. If you remember your immunology or histology, there should be normal B cell tolerance that gets rid of abnormal B cells as they are being formed. But in lupus, that whole process is sort of broken down. And we think that that's central to the pathogenesis of this disease. Even as we say that, we don't fully understand everything about how B cells work. But more recently, and this was published in about 2018, and since then there have been a little more, there has been a little more work. But here we learn more about what the B cells do in lupus, where a subset of B cells were identified to be greatly expanded in lupus and be major drivers of the inflammation that we see. These cells are called the double negative 2 cells. So not just, so these are a subset of cells that lack the normal expression of IgD and CD27. And not just lacking those, they also lack CXCR5. And so they are a real niche subset of double negative cells that we think would be important. And in the years to come, we'll be hearing more about how these cells influence lupus pathophysiology. Having said that, it's not just the B cells and that are the major players. Like I said, there is inefficient clearance. So normally when you have breakdown of cellular products, the body tends to get rid of those products. But in lupus, there is just so much breakdown, and then it's inefficient in the way it clears up things. I mean, not just because there's a lot of breakdown, but it's not just as effective. And so you have a lot of those debris forming, going to stimulate neutrophils and causing what we call increased netosis, which has been another area that has been widely studied in more recent times. More recently, we've also found that other blood cells are actually involved in the pathoetiology of lupus, specifically the red blood cells and the platelets. So for a long time, we imagined that these cell lines were just contributors to the process, in that they were bystanders and not really major influencers of the process. But more recently, and this was a study published in 2021 by Dr. Virginia Pasquale's group, they showed that there was inefficient, there was mitochondrial dysfunction that contributed to systemic lupus pathogenesis. And that was from the red cells, where patients with lupus had retained mitochondria, which we know doesn't normally happen in the normal red blood cell development. And this retained mitochondria was correlated with increased disease activity in lupus. Similarly, we know more about platelets now. And we know that platelets not only serve to cause clotting, but also are drivers of some of the inflammation we see in lupus, not just from the complement activation, because it breaks down and produces some cellular products called DAMs, but also that they actually have direct effects that influence activation of inflammation in lupus. And that is their interaction with endothelial cells, like demonstrated in the cartoon over there, with ICAM1, VCAM1, E-selectin, and all the chemokines. But they also have different effects that directly impact activation and GC formation as well. So let's recap a little bit, because basically lupus pathophysiology is not just one system, and you have a lot of players involved. So we do know that it's both the innate and adaptive immune system, like I described, and there is direct cellular injury, like I described, with the complements activated at tissue level, and then there's immune complex deposition also. So like I said, lots of problems with the apoptosis, as well as complement activation, then the T cells on one side, helping to spur on the B cell hyperactivity that occurs in this disease. And of course, the platelets and red blood cells. So having said that, now that we know that there's total breakdown of the immune system, how do we identify lupus? When you see a patient, how do you make the determination that the patient has lupus? The first thing you should know is that there is no clinical diagnostic criteria for lupus, but there are classification criteria. The classification criteria were actually derived initially for research purposes so that we could, as researchers and in the broader rheumatology and rheumatology community, when we talk about lupus patients, we were talking about the same thing because the disease is so homogeneous. But in the absence of clear clinical diagnostic criteria, oftentimes clinicians do lean to using the classification criteria as a guide in making their diagnosis. The first classification criteria actually was from the first that was more commonly used from the American College of Rheumatology, which was revised in 1982. And many times this question is asked in several exams. You know, how many criteria would you need to say this patient had lupus? And usually it's to have at least 4 out of 11. And this criteria spans not only the skin findings or mucocutaneous findings, but also pleuritis, the kidneys, neurologic findings, hematologic disorders, immunologic disorders, and then of course having a positive anti-nuclear antibody. As shown in the pictures there, for example, the malar rash over there, where it's a nice distribution over the cheeks and often spares the nasolabial folds. As you can see over here, how these are like really nice and clean. Meanwhile, the rash is all the way here. And then things like discoid lupus, which is kind of like this. And then, of course, the photosensitive rash. The oral ulcers for this criterion referred to the palatal sores, as could be seen here. Sometimes it's more of an erythema, not overt ulcers, but here you can see some ulceration in this patient. Following the ACR criteria, the SLIC criteria came into being in 2012 to sort of improve upon the ACR criteria, particularly for diagnosis within identification within the pediatric space. And I'll show you in a later slide how we compared the sensitivity and specificity of these different criteria. But the SLIC classification criteria actually is broader in the sense that it has more under the immunologic criteria. The ACR criteria had mostly the ANA, the positive anti-double-stranded DNA, but the SLIC criteria went ahead to adding some other criteria like antiphospholipid antibodies as well. And then the clinical criteria was broadened to include, you know, not just 1 or 2 types of skin manifestations, but took into account the different ways the rash in lupus can present on the acute cutaneous, chronic cutaneous rashes as well. And then included nasal ulcers, but also for the oral ulcers, did not just limit it to the palatal ulcers, but sores that could occur in other areas of the mouth as well. The other thing the SLIC criteria did was not just look at needing to check off 4 criteria to make the determination, but also accepting if a patient had biopsy-proven lupus nephritis, which is when lupus affects the kidneys, and the patient had a positive ANA or positive anti-double-stranded DNA, it could be considered to have lupus. And so that was a major difference comparing the 2 criteria. In 2019, there was actually an improvement, further improvement on that with the EULAR ACR classification criteria for lupus. And here to qualify for consideration for having systemic lupus, this criteria would require that patients had a positive ANA. Unlike the other criteria, the ACR and the SLIC criteria, that was not an absolute requirement, but for the 2019 EULAR ACR criteria, it is. Another thing it did was give weighted points to the clinical domains and the criteria that were positive as shown on the table. So having said that, when we compare how sensitive and specific these criteria are to helping to determine whether there is, this is systemic lupus. You can see the SLIC criteria worked better in the pediatric population in terms of sensitivity, not great for specificity. The EULA criteria seems to be doing better in both domains relative to the ACR and SLIC criteria. So as a clinician, if you suspect lupus, what should you do? You know, it's not just looking at the criteria. The first thing is history and physical exam. History in particular, because the history will drive you to getting tests. And it's important because, particularly in rheumatology, getting those tests in the absence of having a clear picture sometimes could be misleading. So much so that the ACR published in 2014 specifics saying that, you know, you need a higher index of suspicion before you go ahead to order some tests, and particularly if you have, do not order autoantibody panels unless you have a positive A&E test and there's actual evidence of rheumatic disease. Otherwise, there could be, like I said, it could be misleading and not, you'd have a hard time interpreting the blood work that you have obtained. So let's talk a little bit about some of the blood work. So after a patient has a history that's suggestive that something may be going on, things like probably unexplained fever for a certain duration, weight loss, hair loss, sores in their mouth or nose, maybe a family history of rheumatic disease, in addition, and maybe arthritis. You go ahead and order tests like the ANA. The ANA test is actually one of the most common reasons for which we as rheumatologists get consulted on in the outpatient setting, because pediatricians would have gotten the ANA test and it's positive. So it's a very common reason for which we are seeing. But it's not, it's part of the puzzle. It's not the entire picture. So what are these ANA? They're basically a group of antibodies, not just one antibody, it's a collection of antibodies that are directed against predominantly nuclear components. Majority of them are IgG class antibodies. And they can be found in several rheumatologic conditions and not just lupus, hence the need for the history taking and everything else. They can also be found in up to 20% of healthy children. It's oftentimes lower titer positive in those children, but then that's something to also remember. It's also important to remember that it could be found in infections as well as malignancies. But either way, in the setting of lupus, it's a very important marker. And for us, the indirect immunofluorescence is actually the gold standard for testing for this. And that's because it's most sensitive and specific that way. So the substrate is actually mounted on a glass slide, and then the antibodies are labeled with fluorescent tags to identify the presence of an antibody in the substrate. And this is using the HEP2 cells, which are a monolayer of cultured human epithelial cells from laryngeal carcinoma, because they contain a lot more repertoire of the antigens that we look for. Another way we test is called the ELISA, which is an enzyme-linked immunosorbent assay, and it could be done in two ways, either direct and indirect, which I'm not going to delve into too much because I know you already have an idea of what those tests do. But having said that, so when you say a child is moderate or high titer positive ANA, they may not always fulfill all the criteria because some of those manifestations I talked about may take time to really to show up, and it can come from anywhere from days to years. But what we always say is that if someone has a high titer, moderate titer ANA positivity, and at least one other lupus classification criteria, it's very important that that child be followed periodically and reevaluated for developing the definitive lupus. I say this because there's often a delay in diagnosis. Like I said, it's a heterogeneous disease and it might take time to fully express itself. You don't want to miss the opportunity of being able to intervene early and have the patient evaluated and sent to a rheumatologist until it's too late. And so just keeping those kids periodically followed is what we tend to do. So like I said, the ANA is like a broadly checking to see if you have autoantibodies. It's a group of antibodies. And so when it's positive, the first thing, the next thing that happens is that we look to see what exactly it's positive to. In the next series of slides, I'll talk about this test in particular, but I'll first talk about the double-stranded DNA, which is another common one that often features on tests. It's actually present in lupus patients as well. And it's not just having a double-stranded DNA, but we refer to the high avidity IgG anti-double-stranded DNA, because the lower avidity double-stranded DNA may be found in other diseases, other rheumatic diseases like Sjogren's syndrome, rheumatoid arthritis, autoimmune hepatitis. But in lupus in particular, we're referring to the high avidity IgG anti-double-stranded DNA. And similar to testing for an ANA in general, we can use the ELISA, but more interestingly, with the double-stranded DNA, we do the immunofluorescence with Crithidea, which is, the Crithidea is a flagellate parasite that we use to help us to determine how high of a titer we have with the double-stranded DNA. The good thing about this antibody is that it is pretty specific for lupus in children, and it's pretty sensitive. It is associated with kidney disease in lupus, with disease activity, and so it can fluctuate with disease activity. And so we not only use it for diagnosing lupus, but also in following disease activity over time and response to treatment and things like that. Now, talking about the actual extractable nuclear antigens, which is kind of what the ANA test will reflexly check for if it's positive. These refer to tests like the anti-Smith, the anti-RNP, which is a ribonucleic acid protein, the anti-SCL70, as well as anti-centromere. Those are some of the extractable nuclear antigens. And they're a broad group of antigens that basically get the name because they're extractable from the nucleus with saline in the lab. They're antigens from both ribonucleoproteins as well as non-histone proteins as well. Within the space of lupus, anti-Smith is one of the antibodies that is extremely specific for lupus and for lupus nephritis, but just the presence of lupus. So like I said, if a child has for example, has high positive ANA, has a positive Smith, but doesn't have a lot more going on, maybe has some hair loss or non-descriptive fatigue, you might still want to follow that child closely and periodically with time, because the positive anti-Smith is highly specific for lupus, and the child may eventually develop lupus. Anti-RNP is another one that's seen in 30 to 40% of lupus patients, but also seen when lupus overlaps with other diseases, as seen in mixed connective tissue disease. The anti-SCL70 is seen in 5% of lupus patients and could be seen with systemic sclerosis, pulmonary fibrosis, and as well as anti-centromere. So those are less frequently seen with lupus, but still they have implications when they're present. So let's look at this slide for a second. This is a 13-year-old female with a 1-month history of weight loss, intermittent fever. Her exam showed palatal ulcers and swelling of the joints of her hands and knees. So basically she had arthritis. Her lab showed positive ANA 1 in 640 with a positive Smith and low C3 and C4 complements. Now I want you to pause for a second and think, does this patient have lupus or not? Okay, if you want, you can write the answer in the chat, but I want you to generate an answer for yourself. Do you think she has lupus based on everything we've said? Do you think she has something else? All right. All right, great. So I'm going to give you another example. The 12-year-old male with a 1-year history of hypertension, 2-week history of bilateral ankle and foot swelling. His labs showed positive ANA, also 1 in 640, low C3 and C4 complements, and had a double-stranded DNA positive at 1 in 80. This time, the urine showed 2+ protein, numerous red blood cells, and hyaline casts, and a urine protein to creatinine ratio of 1. His echocardiogram showed pericardial effusion. Again, do you think this child has lupus? Okay. So both cases were clearly cases of lupus, and it's, you know, they have a lot of features that go with that, but there's sometimes it doesn't always happen that way. You might have a child that has like something that presents with an acute abdomen, and maybe a positive ANA, maybe a history of weight loss and not much else. And yet the child ends up having lupus mesenteric vasculitis and ends up having a diagnosis of lupus eventually. That does happen. Again, the disease is so homogeneous that I often say not one patient with lupus is the same. Every child tends to be very different. So having said that, we still don't understand lupus fully. We can recognize when they're really florid symptoms and when it's very obvious, but when it's not as obvious and it's subtle, then we may have difficulty. And so there's still a lot of research in trying to figure out what's the early, a good way to diagnose lupus early, what are good biomarkers for lupus. And also when lupus affects end organs that are really severe, you know, how can we identify those? How can we better understand those end organ effects and improve outcomes when they have those end organ effects? This slide I'm showing you is from a group of pediatric rheumatologists, nephrologists, and dermatologists in the US and Canada. Those are national bodies that came together to determine what we should focus on research-wise for juvenile lupus. And you could see the top of that was lupus nephritis, which is when lupus affects the kidneys. But the top 5 included lupus nephritis, the clinical trials. We need biomarkers. We need to better understand neuropsychiatric disease and then refractory skin disease. Of course, there are lots of areas that we needed work on, but those were high areas of high focus and high priority. So in the next few slides, I'm going to focus on lupus nephritis and then neuropsychiatric disease for that reason, because those are 2 major end organs that are often affected in lupus and cause significant morbidity and mortality, and may be difficult to diagnose in an already difficult to diagnose disease. So what is lupus nephritis? Like I said, this is inflammation. It often involves the glomeruli and the interstitium. The interstitium there because for a long time, we didn't realize how much of the interstitium was affected by lupus nephritis and focused a lot on the glomeruli. But we know that we have renal formation of immune complexes as well as deposition of immune complexes from, you know, the bloodstream and things like that. We also have T and B cells forming lymphoid aggregates within the renal tubulointerstitium as well. And so there's a lot of inflammation there, so much so that when you look at it under the microscope and under immunofluorescence, it gives us a pattern of what we call the full house pattern, where we have deposition of IgG, IgM, IgA, C3, C1q, kappa light chain, as well as a lambda light chain. And this is important because this full house picture helps us oftentimes in determining that this is lupus nephritis. It's near pathognomonic. And I say that because if you recall, I talked about the different types of classification criteria, and the SLIC criteria made reference to having a biopsy that looked like lupus nephritis. And even if you didn't have a ton of other features, you had the positive ANA or the double-stranded, you could still make that diagnosis. And it's important because some patients come presenting with overt lupus kidney disease and may not have a lot of the other things, but you have to act on it because it has poor outcomes if you don't. Skip this slide. So initially, the World Health Organization classification was what we used to use. And it had, the 6 classes, and we would look at active lesions, sclerosing lesions. We improved on how we classify lupus nephritis that way in 2003. And this is the classification put together by the International Society of Nephrology and the Renal Pathology Society. Similar to the WHO classification, it also looked at lupus nephritis in 6 classes, but also it went further to better define what we meant by focal and segmental or global involvement, as well as active lesions and chronic lesions. So much so that we have also the activity index and the chronicity index, which are other things that we look at, not only describing where's the information going on within the kidneys, what part of the information and how much is the information, but also determine how active, meaning what kind of cells are we seeing, and how chronic, in essence, how much damage do we see, because that also impacts outcomes. Moving back into the clinical space a little bit, I do like to talk about this study. It's one of the large studies we have in pediatric lupus, and from the consortium of the North American rheumatologists, and that's from North America and Canada, and some of our colleagues from Brazil and other member states within the CARA registry, and that's the broad name for our group, CARA. We looked at the cohort to see whether the things that we believe about lupus nephritis, are they really true? So there's some certain principles that were gleaned by looking at the literature. And we looked in this cohort because it happens to be one of the largest multi-center cohorts we have, with a lot of data to see whether those things that we know from the literature really do continue to be a problem for us today in our contemporary society. So like what we have always known, lupus nephritis does affect a significant proportion of children. And so anywhere from 36 to 55%. So that's one of the principles. The other principle we said was that lupus nephritis often develops in 1 year of diagnosis. That's about 80%, and then 90% develop within 2 years of diagnosis. And then we look to see whether it's more often membranous than proliferative. So membranous, I didn't go through the classes in total, but class 5 is kind of a membranous picture where patients have a lot of protein poured out. And then the proliferative is the one that's particularly very rapidly damaging, where you don't only have protein, you have red blood cells and a lot of hypertension and just very aggressive disease. The thinking is that membranous more often presents with a lot of proteinuria than does the proliferative type. So that was another principle they wanted to check. The other thing they wanted to check was whether short-term kidney outcomes were worse in Black patients versus non-Black patients, and whether those kidney outcomes were worse in patients who present with already a bad glomerular filtration rate of like 1. They also wanted to look at some medication effects like rituximab. So what did they find? So same as in the literature, 32% of that cohort actually had lupus nephritis. And the vast majority were diagnosed within 1 year. So the first year was 73% and 93% within the second year. They also found that those outcomes were, the short-term kidney outcomes are actually worse in Black patients versus other patients. We couldn't quite answer the rest of the questions because the database didn't give us much granular detail, particularly with the proteinuria question. So having said that, we can see that we still have similar issues that we have dealt with lupus nephritis even in children. And so that this, so much so that this 2017 article on renal outcomes in juvenile lupus is important to also remember what we're dealing with. Like I've said, renal involvement in lupus oftentimes is bad news. In terms of end-stage renal disease, for example, 1/3 of lupus patients with lupus nephritis that have end-stage renal disease end up on dialysis and end up needing transplant within 5 years. And then those on dialysis, the outcomes are still pretty bad, where there's a mortality rate of 22% at 5 years. So we'll switch gears a little bit and talk about neuropsychiatric disease in lupus. And if there is something as confusing as, more confusing than making a diagnosis of lupus itself, is making a diagnosis of neuropsychiatric lupus. In essence, are you sure that it's lupus that's affecting the brain or not? It's often the problem with attribution, because it's so homogeneous that, and can occur, the neuropsych manifestations can occur outside of a patient having lupus. Sometimes it gets very difficult to determine whether it's lupus causing the disease or not. But for all we know that neuropsych complications can occur in up to 60% of children with lupus, and 70% of this often occur in the first year of diagnosis. However, it can present at any time in the course of the lupus disease, and is associated with long-term damage and morbidity. In a single person, you could have more than one neurologic event, neuropsychiatric manifestation. It doesn't have to be just the one. So back in the day, we only understood these neuropsychiatric manifestations to be maybe coma and stupor, which was very, very brief. We expanded this in 1982 to seizures and psychosis, and tried to get a better handle on things in 1985. But it was not until 1999 that we had better way of looking at neuropsychiatric lupus, where the ACR devised standard nomenclature and definitions encompassing about 19 definitions and classifications broadly under central nervous system and peripheral nervous system. In children, we have a lot of the central nervous system effects, in particular things like headaches, of which benign intracranial hypertension falls under, cognitive dysfunction, mood disorders, seizures, psychosis, and cerebrovascular disease, also known as strokes. So it is complex, like I said, and there is no gold standard for diagnosis of neuropsych lupus. And sometimes we get brain imaging trying to help tease things out. And sometimes the brain imaging is normal, many times it's normal. And I have to reiterate that a normal brain imaging does not exclude a diagnosis of lupus, neuropsych lupus, because brain imaging modalities still have limitations. And so we still don't have a good grasp of this manifestation at all. And the reason for why lupus affects the brain or the rest of the nervous system and how it does that is still not very clear. We have an idea that, the blood-brain barrier is breached. The blood CSF barrier is also more porous. There might be direct neuronal damage. There is vasculopathy, thrombosis, other inflammation, whether it's directly within the brain, the CNS, or peripherally and transferred to the brain. And then the impact of other antibodies and cytokines and apoptosis, but we still don't have clear mechanisms for all the manifestations in particular. So I do like this classification that was published in 2020 that looks at it under ischemic and inflammatory pathways. But if you look in this table, the first thing you notice is that the clinical phenotype at the end of the day, there is such overlap, in essence saying that there might be both pathways occurring simultaneously, and definitely there might not be just one singular pathway. And this has made diagnosis challenging because that just tells you that perhaps the biomarkers for neuropsych lupus might not be a single biomarker, but you might have to look at a bunch of biomarkers to be able to determine, what pathways are at play and what you can measure and help you make a diagnosis. Further compounding this, I've alluded to in my earlier speech, is that there is the problem of attribution. In essence, there are things that you're not sure whether it's lupus causing this. For example, does the patient have a primary psychiatric disease, or is this steroid-induced psychosis from the medication, or is this actually lupus doing this? And then again, what makes this worse is that you could have neuropsychiatric manifestations in the context of overall active or quiescent lupus disease. In essence, the blood work that we usually check to look for how active lupus is systemically may be normal or near normal, yet the patient has florid psychosis or florid other neuropsychiatric manifestations. And so it makes it sort of a challenge. But for what we do know in terms of other antibodies that can be important in neuropsych disease, the anti-phospholipid antibodies is one of the first that we know about that increases risk of thrombosis and has been linked to cognitive dysfunction, an increase in incidence of white matter hyperintensities on brain imaging. But then that's just one subset of neuropsychiatric manifestations. Similarly, the anti-NR2 antibodies also has been shown to, be associated with cognitive dysfunction, but then these antibodies are not always present in those disease states when you have patients manifesting those symptoms. And so it's not always specific or sensitive for these conditions. The ribosomal P antibodies, for when it first came out, we were really excited, thinking that it might, be the biomarker that would help to determine for sure that a patient has neuropsychiatric disease. It's found in about 10 to 20% of adult lupus patients and 20 to 40% of pediatric lupus patients. However, the initial thought that it was definitively linked to psychosis has been refuted in several other reports. So really at this point, while it may be helpful in helping you diagnose lupus or teasing things out, it's not as specific, and the clinical utility that we were really expecting for this antibody hasn't materialized. Anti-neuronal antibodies are another one that's promising as well. These are antibodies to neuronal antigens, and there are studies that showed that it was present in a lot of patients with neuropsychiatric disease. However, these were all small studies, and so they need larger studies to understand the sensitivity and specificity to further validate the findings. Another reason for why we do not just say because a patient has a normal brain MRI, the patient does not have neuropsychiatric disease, is because basically some of this, the modality we use sometimes for imaging, we may have to use more high-end imaging to be able to pick up subtle signs. And so this study looked at patients that seemingly had no overt neurocognitive deficits, but their brain imaging using more advanced imaging techniques showed that there was already blood-brain barrier integrity loss, and they were able to show that the pattern of the blood-brain barrier integrity loss was similar to other reports where patients actually had overt cognitive dysfunction. And so the conclusion of that study was that blood-brain barrier integrity loss does precede the loss of cognitive ability and starts earlier, and perhaps, continuing to look for a good multimodal imaging technique or approach to diagnosing neuropsych disease is still very relevant. Similarly, looking at brain autopsies, there's a study that looked at about a number of patients and found that in patients that didn't have overt neuropsych disease, there was actually evidence of a vasculopathy already present, even at the time of though they did not have neuropsychiatric lupus. And it was similar in patients that had overt disease. So basically, lupus can affect the brain. We just don't have good way to diagnose for sure. But then you should have a very high index of suspicion, particularly when you've ruled out other causes like infection. And even if you have a normal brain MRI, it does not exclude the neuropsych lupus diagnosis. And it's so important that it was captured in the SHARE recommendations by Euler, specifically saying a normal MRI of the CNS does not exclude neuropsych lupus. I continue to harp on that. I'll switch gears a little bit and talk about how can we improve care and outcomes. So we have done so much so far overall, the mortality rate, though I talked about bad numbers, they were far worse about a couple decades ago. So we are inching in the right direction, but we still have so much more to be done. And so in terms of treatment, things we do use are things like hydroxychloroquine, which is quite popular, and almost 90+% of patients with lupus on hydroxychloroquine, except that it's a major contraindication. Methotrexate, mycophenolate have been used as well. And of course, we do use steroids. A lot of those medications, we use them in a bid to get away from using too much steroids, because steroids have their good sides, but they also have their side effects. Other medications we've used have been like cyclophosphamide, which also we use in cancer care, but we do use it in the space of lupus, particularly for lupus nephritis and neuropsych lupus, or like severe manifestations of lupus in general. Same with mycophenolate. More recently, we've had biologics which have come on the market, things like rituximab, and then belimumab, which actually was the first biologic that was FDA approved for the treatment of lupus. So there is a lot going on in the space of drug therapies that can be used to treat children with lupus, not just on the adult side, and looking at the different pathways that could be affected in lupus, trying to target those pathways to see whether we can get on top of the inflammation. So as you see here, we have anti-CD38 trials with daratumumab. We have the anti-IgE trials as well. And like I said, belimumab was successful, which is an anti-BAFF agent. Anti-CD20 agents, right, rituximab, we didn't get the outcome we expected with the clinical trials for rituximab, but still in the clinical setting, we see that it does help our patients. And so it's a very commonly used medication for lupus, particularly juvenile lupus at this point. There are, of course, ongoing clinical trials and studies that are not on this pictorial, things like obinutuzumab and ifronumab that are promising and hopefully will give us more in our repertoire to take care of these patients. But it's not just the drug part of things. We look at medication, but we also know that to improve outcomes, apart from research, we also have to look at the patient and have a more patient-centered approach to deciding on medications and care. And so right now, there is more of a talk for a treat-to-target approach, basically working with the patient on shared decision-making, not just only on making decisions about the treatment, but also the strategies and other aspects of the care that are important for the patient. And this is it's going to be truly at the core of how we practice in pediatric rheumatology and taking care of these patients, and understanding that it has to be many times multidisciplinary and not just one single specialty. And that brings me to the question of how does the general pediatrician help in caring for a child with lupus? In several ways. Prior to training as a pediatric rheumatologist, I was a general pediatrician, and part of what we do best is early identification of diseases and getting kids sent to the right specialty in a timely fashion. And like I've gone through all the things that could happen with lupus, you can see that early identification is actually very critical. And so that's a crucial role for the pediatricians. And so this lecture, I hope, has been helpful in pointing out that, getting the ANA test needs to be backed with history and physical exam that matches your suspicion, and then quickly referring those patients once you have your results back, and even when you have your suspicion, tying in your rheumatologist at that point. When a child is diagnosed, there is still the role for the pediatrician and not just the pediatric rheumatologist. Things like in ensuring the child has the vaccinations that they need, in particular the pneumococcal vaccine, because these kids are at risk of having pneumococcal disease, mostly from complement and their immune dysregulation. So we try to give them a broader coverage with that vaccine. So just making sure the kids have their their vaccines as they're supposed to, and then the avoidance of live viral vaccines when they are immune suppressing agents. In helping them being successful at school, many times they need adaptations at school. We have to make sure that they have allowance to use sunscreen at school, be able to leave school for their appointments and their medication and things like that. The school should recognize that they would be at higher risk of infection, and we need to make sure that they're intentional at preventing them from being exposed to infectious states. Also, they still need to have their annual physicals with their pediatricians. That's very important, in particular for adolescents, and as they try to make their transition to an adult provider, helping them get ready for that transition is very important. And of course, for acute concerns, many times the pediatric rheumatologists are very few. And so it's always great to have a partner with the general pediatricians, because sometimes they can see the patient quicker than we can, and then can also talk with the rheumatologist as well. And so basically in the last few minutes, I've been able to go through a lot of things in concerning juvenile lupus. First of all, giving an overview of the disease and epidemiology and pathogenesis, honing in on diagnosis of lupus and the limitations of our clinical criteria, as well as talking about neuropsych disease and lupus nephritis, and then honing in on the role of pediatricians. Thank you all so much for listening. And I think at this point, I'll be ready to take questions. Thank you.
Thank you, Ekemini, for this very, very comprehensive presentation. I think it's a great overview of what is struggling with lupus. And I think we have time for just one question before the closing of the session, but I think it is an interesting question. It's how to differentiate or how to assess the neuropsychiatric features when the kids are struggling with dealing with a chronic disease, and then the family is very stressed. So maybe the kid has problems at school because of that, and not of lupus. So what do you think are how to assess that part?
Right. So I think I echo you. I mean, that's a very, very relevant question, because it builds on the question of attribution. So yes, there would be issues with coping with disease, coping with a chronic disease and a heavy disease like lupus, and in adjusting to that disease. But then there are also definitive cognitive dysfunction, because lupus also directly affects the brain. And really optimizing the treatment for lupus in that kind of scenario would be very key, and definitely supporting the child to deal with the other psychosocial effects of lupus, of dealing with a chronic disease like lupus, is necessary. And that would help you over time tease out what's actually going on. It's hard to make that clear determination with just a one-time point. Sometimes it's over time. But as long as you're recognizing that lupus can directly affect the brain, so making sure you're measuring things like getting a formal neuropsych testing, screening, having your clear way for you to track the neurocognitive dysfunction. If there are no brain MRI changes that you can see or things like that, there are tests that have been found to be helpful. I didn't talk too much of those things like the PEDA, but having a formal neuropsych testing would help. And then supporting the child through that process and the family with the psychosocial support. Definitely, if it's in the setting of overt florid disease, you definitely have to treat if you have inflammatory markers that are up. But then also, like I said, sometimes even when what we usually check to monitor disease activity may be normal, and the child still has neurocognitive dysfunction from lupus, you still have to address that. And there are actually now even further studies looking at ways to improve that improve fatigue, looking at interventional methods, not just drugs, but from the psychology aspect. And that has been shown also to be helpful. I didn't delve too much into those clinical trials, but there are a number of opportunities right now going on specifically for children with lupus, not just adults, but in the pediatric space.
Thank you, Ekemini. I give you the word to Dr. Oscar Valencia for the closing.
Thank you. Thank you very much, Dr. Ogbu, for your extraordinary lecture. Very usual for the pediatrician. It's going to be a very useful lecture. Thank you very much for being with us in our weekly grand rounds, and really appreciate to see you in another time. Thank you very much, Dr. Ekemini Ogbu.
Thank you.
Muchas gracias. Muchas gracias a todos nuestra audiencia. En particular, quiero agradecer a la doctora Nadina Rubio por la conformación de este extraordinario módulo, al doctor Fernando García por la conducción del mismo. En este módulo revisamos 5 temas muy trascendentes de reumatología pediátrica, artritis reumatoide juvenil, la transición de los pacientes cuando pacientes pasan a ser adultos, adolescentes y adultos, cómo hacer la transición, la esclerodermia, el síndrome de activación de macrófagos y ahora en esta sesión la de lupus eritematoso sistémico. Muchísimas gracias a todos. Los invitamos que para el próximo mes tendremos un módulo de infectología. Va a ser muy interesante. La primera sesión, que será la próxima semana, se hablará sobre vacunas RNA modificados. También veremos otra plática sobre tuberculosis, la siguiente sobre hepatitis y finalmente el uso de antibióticos.